check, check. Alright then. I guess my my audio's right. And update complete. Alright, so here's what I'm looking at. Well, start at the beginning. Is that readable? It's not the right one. Well, that's it. This is it. It's 27 pages of my first part, part one of my thesis. I fast forward to the end. I guess this is the most important part. Just let me fuck. Alright, so this is the most important part of the first part of my thesis. Part one of my thesis is about supply chains. This was 2018, late 2018, early 2019, March, Yeah. So, laid off, hospitals shut down, all non-necessary people. Lockdowns were just starting, not all the way started yet. So my issue was the supply chains. So I developed. Okay, long story short. Long story short. Developed a method to in 2019, mid 2019, to keep supply chains functioning and also possibly resilient during a crisis. Any crisis. Almost any crisis. So, what it is the iterated. Oh shit, I started at the beginning, my bad. I fucked up. So, I thought COVID 19 was gonna mingle with the flu, but little did I know that the flu was just gonna take a couple years off and just disappear. You know, the normal flu we get, like the influenza, which means the influence. I thought that was going to commingle with COVID 19 and then exacerbate some issues. I was a fucking dum-dum. The flu took a break. The flu decided it's somebody else's turn. The flu was equitable. The flu, turns out, the flu is socialist, and it decided that it had enough, and some other virus is infectious disease. It's their turn now because the flu had enough. So that's very kind of you, Mr. Flu, or Mrs. Flu. Who knows? But so I nailed this wrong. I got it way wrong, and I actually pivoted towards this mid-paper to try to, because it made sense. But what didn't make sense is that the flu took a break, so I fucked that one up. But the core of the paper is about the materials atrophy triangle that I developed myself using golden ratio derived trigonometric iterations to sustain and possibly make resilient crisis supply chains. So that was the beginning of it. That was part one. Part two went a little heavier. Part two, and it should have only been one part, obviously. Like a thesis, most likely should be only one part. Otherwise, you should start another thesis. But in this case, I thought it continued because we, as a society, as a globalizing species decided to collapse all of our supply chains intentionally. We decided to stop producing things. Elon Musk said, and that's a fallacy, invoking authority, but he had a good quote that said, if you don't produce stuff, you won't have stuff. And that's what we did. We went ahead, and this is after this. So I'm just talking 2018 to present. What we did is offshore everything and trust in China and all that. That's a whole other different story, which is important, but I can't cover it right now. So what we did is, after we offshored everything, we just stopped everything. We collapsed all the small businesses. We collapsed all the supply, all the good supply chains, all the massive supply chains. We, the government is who is we right now, focused all our flow of money, all the taxpayer income on the huge corporations and the Silicon Valley oligarchs, the Amazons, the Walmarts. Everything else causes harm. So you have to shut down the mom and pop stores because that's where the virus attacks. The virus doesn't attack Walmart. It doesn't attack Amazon. COVID-19's pretty damn smart. It's weird. So halfway through my thesis, I'm like, shit, we're collapsing these supply chains on purpose. So why the shit am I even working on ideas to keep supply chains floating and consistent, and keep toilet paper in your bathrooms? That was the whole point of my thing. And it turns out the government doesn't care about that. The government's not focused on that. Government doesn't care if supply chains function. And more than care if supply chains function, they're actually putting into implementing and inaugurating policies that collapse the supply chains. So it's like, well, goddamn, if you're collapsing the supply chains, why the shit am I trying to keep them open? So I had to pivot halfway through my thesis, which kind of hurt my brain, hurt my grades, hurt my career. I no longer work in any hospitals. Everything's shitty because of COVID policies. So I guess the first year and a half of my master's research on my thesis was just a preamble to get me to the red-pilled truth of my research question. Which is, what impact do the COVID-19 specific policy changes by public health entities have on governmental COVID-19 mortality reporting, methodology, and trends in American healthcare systems since 2019? So that's a lot. That's a mouthful. So public health entities, we know them now as the WHO. What's your booty? What's your booty, girl? Public health entities. WHO, NIAID, NIH. Oh, we all know it well. Like, that's common knowledge now. A couple silver linings, devil's advocate. PPE is now a common term. It wasn't a common term in 2017. Nobody knew what PPE was. Nobody knew what N95 was. Now that's common term. I bet you if I say Philly Blunt, you know what that is. I bet you if I say PPE, you know what that is. 2017, that would have been a very different story. So the public health entities have on governmental COVID-19 mortality, death, morbidity diseases, but mortality reporting. So death reporting methodologies. So it seems like an innocuous question. It's like that's not, you know, like what are these government policies? And I'm just going with American government policies, but we understand that it's not American now. It's the WHO and the CDC are implementing globalist policies, the borderless policies, one-size-fits-all policies that, well, I don't want to spoil the end, because the end is the impact, and we're living through the impact, and we are experiencing the impact, and that's a whole other side effect called devolution, which hopefully in the future I could go into. But this is what I have to stick to my wheelhouse right now. But I did email Patel Patriot to see if he wanted to get into something that I know about these policies and their impacts, the impacts on the reporting. Reporting methodology. So, public health entities, you think they would be most concerned with the health of the public, but that's not what happened during this pandemic. This pandemic was a very different and unique pandemic than all other pandemics in recorded history. We, as in governmental agencies, handled this pandemic almost exactly opposite the way we would handle every other pandemic. To our detriment, I would elucidate. But so the mortality reporting and the methodologies and trends in American healthcare systems since 2019. So, what had happened was throughout all medical history, all recorded medical history, scientific medical history, we did things a certain way. You protect the young, the vulnerable, and the elderly. Which makes sense. Like, you do that in war. A pandemic is basically a war. So, Trump said he's a wartime president. He's not lying. So, throughout all pandemics, you want to protect the vulnerable, which is the young, the infirmed, and the elderly. In this pandemic, our government agencies put forth policies that attack the elderly, attack the young, and compromise everybody in between. That's a huge claim. That's a very huge claim. I have to back that up. And that is the core of my thesis, is backing it up. So what I'm going to do is find my, I did an elevator pitch. It's basically about a 15-minute pitch to, about this. gonna play it.
Okay.
Hello? And you'll have to forgive me because I'm sober in this, so I'm nervous. But so this is the elevator pitch. Some of my friends, if anybody's watching, they already saw this. But if nobody's watching, then this is heuristic and heuristic. But I'm editing it right now as I'm talking. Need to light my cigar. But this is I don't want to leave for a second to get some more woodruff fucking drink. But so this is my elevator pitch. This is my capstone presentation for my thesis.
Okay. Hello, my name is Chris Butcher. I am a master's graduate student at Eastern Michigan University. This is the second part of my thesis, where the first part was about supply chains in the pandemic, and that led me to this part as the policies of the pandemic. So I'll just jump right into it. So this presentation is a condensed elevator pitch of my research. I'm going to go through this data pretty fast. So a rift is formed, a split from the precedents in the recording, aggregating, and reporting of pandemic data. There are at least two distinct data sets that are difficult to compare to each other, that of pre and post March 24th, 2020. This disparate treatment and the data dissemination can be linked to most of the harm caused during the pandemic. The emphasis of this presentation is to show the movement away from the benchmark best practice standard operating procedures like tracking, following, and treating clinical signs and symptoms, which are the infections, and towards vaguely defined cases and bottleneck testing protocols. So in all past epidemics, pandemics, and endemics, these two forms of pathogenic measure, which is cases and infections, shared a one-to-one relationship. So what changed? So here we have our graph. It's August to August. CDC goes by seasons. So it's centered on the flu season. So we have years 2014 to 2020. And what you can see is that for the first year and a half of the pandemic, the deaths were tracking normally. That means they were following the pattern of deaths from previous years in 2019 and 2020. So the virus didn't cause any significant unexpected deaths for the first year and a half of the pandemic. Then all of a sudden, March 24th, around that time frame, 2020, the numbers boosted. So what boosted these numbers? And so we could see that it wasn't the variants, because the virus didn't change yet. The variants aren't even on the graph. Those are over here in September and December, alpha. That's when the variants kicked in. So the virus didn't change. So what changed around this time frame? You see an obvious boost in the deaths. So the policies, we implemented a lot of policies at this point. And looking back now, the data shows one significant impact of the policies is a spike in the elderly and immunocompromised deaths after March 24th. So yeah, with the viral infection of SARS-CoV-2 as the sub-event. So the policies are what's driving the harm, is my hypothesis. So we now know that the impact of these policies is to uncouple the usual driving forces of pathogen spread, such as infection and clinical signs and symptoms, and instead artificially insert the RT-PCR, which is reverse transcript polymerase chain reaction test, as the driving force behind the pandemic. So that led me to my research question, how are these policies impacting how we record, how we gather up, how we aggregate, and how we report our data? And this is Shijin Lin. She is the most important virologist in the pandemic. My working measure is, if you don't know who Shijin Lin is and you don't recognize her, your working knowledge about the pandemic is basically a 1 out of 10. She is wearing the only effective PPE against RNA viruses. This is Xi Jinping. So what we're going to do is get rid of the corporate media hysteria, and we're going to get rid of social media fear porn, and we're just going to focus solely on the data. So what we see, we have in the center column, we have the population data over the past couple years. And what becomes blatantly obvious is that there was no event that decimated the population of the U.S. in the last couple years. To go one step further, there was no significant event that decreased the population of the U.S. So, based on the data, since 2018, no event transpired that was significant enough to slow the growth of the U.S. population. So the U.S. population increased at a normal rate and an expected rate. So in other words, there was no viral pandemic. There was a new virus, but not an extremely dead one, or not deadly one. And you can see for the third year of the pandemic, 2020, so a year and a half, now all of a sudden the numbers jump. And that's directly related to the policies. I believe I'm prepared to prove that. So, where are all these COVID deaths coming from? We have a lot of deaths, it's all over the news. Well, I coined a term called classification capture. So, what the policies did is erase the line between being hospitalized or dying with COVID or because of COVID. So now, suicides, overdoses, and murders are all COVID deaths after March 24th, 2020. I actually saw this firsthand because my job is a mortuary transporter. So I go to the crime scene, pick up the body, take it to the mortuary. We had a suicide. It was a self-inflicted shotgun blast to the face. They swabbed the test, or they swabbed the decedent, because that's their policy, came back COVID positive. That suicide is now a COVID case. So I know the firsthand that classification capture is happening. That's just anecdotal. But this radically and incorrectly boosted the COVID cases and the number of deaths. So the policies directly impacted how we record deaths now. We are less accurate. So we have all the different diseases, the way people are dying through disease are going down, and COVID's going up to almost the exact same number after March 24th. Again, second week, third week in April, same thing. Next week, same thing. COVID is capturing all these other deaths, causes of death. So what would be the incentive of this? Because it's making, if we want to go back and research, this is making all our data less accurate because now it's all just COVID deaths. So what would be an incentive for this? Well, the government incentivized with money. So in places like states like Minnesota, Nebraska, and Montana, they're getting $300,000 per case. Not per infection now, since this is after March 24th, we're moving away from signs and symptoms, which I'll show that the WHO defines a case without signs and symptoms, just a positive test. So now we're getting $300,000 per case. And so you see just this one room, in this one hospital, in this one state, at this one moment, this is $5 million. And this was back in 2020, so we didn't have the vaccines, and we didn't really have too many treatments. Ventilators were on their way. So what they do is they get you COVID positive, they get the test back positive, get the $300,000, then they send you on your way if you can breathe on your own. Next person, please. So this is a huge transfer of wealth. And you can see that New York, they're only getting $12,000 a case. So according to the government, people that live in high population dense areas aren't worth as much as people that live in rural areas. That is a case study in itself, I believe. So since New York is not making enough per person, they implemented some policies that ultimately made up for that in quantity. So what they did is they took normally or otherwise healthy young individuals that are COVID positive now, these young individuals who have a 99.998% survivability rate, they mandated that they start cohabitating with the elderly and immunocompromised. So we put the young people that are almost guaranteed to survive in with our most vulnerable populations. And usually in pandemics We try to protect our elderly, protect the immunocompromised. New York did the opposite this time. And other states did too. Whitmer in Michigan is going through litigation for this exact thing right now. So that's New York's answer to that. And that was implemented on March 25th, 2020. So the WHO started the ball rolling on March 20th. They said, we know what the precedent is, we know how we did medicine for the last couple hundred years where we follow the infections, that's how we know where the disease is, but don't do that, we're going to do something different now. We're just going to do a laboratory confirmation, which is a positive test. So they're not going to look who's sick, we're going to look at who tests positive. So this is a huge break. This is how we get the transfer of wealth. So we're not treating sick people anymore, we're treating laboratory confirmed test positive people. So what is this test? Like this is we're basing the whole future of humanity on this test. So it has to be a good one, which it is good for what it's meant for, but we're not using it for what it's meant for. So I wrote a whole paper on this, but really simply what we need right now is just to know that there's a parameter called the threshold cycle. And that's a dial you could change to show how many cycles go. And if you want the percentage of your specimens to become more positive, you boost that cycle threshold up to 40 or above. If you want more of the test to come back negative and reflect the actual infection rate, you bring it down. Most of the scientists I interviewed, they said around 15 or so is what they're comfortable with. We're at 40, 45. So we're boosting the number of cases, and they don't reflect the number of infections. So, but since the WHO came in and said we don't need, signs and symptoms, we just need this positive test. That's when we start getting into this asymptomatic theory. So now they're pushing asymptomatic, and the CSTE, which is the Councils of State and Territorial Epidemiologists, they jump in and put their new standardized case definition to include asymptomatic infections as well. And so the WHO is pushing asymptomatic to where you're not sick, you're healthy, you're doing push-ups, you're eating your smoothies, but you test positive, well, you're asymptomatic. So what they need is some scientific studies behind them. But what they can't do that because the people that did the science, it shows that there's no asymptomatic spread. So what they did was scientism, which they say they got JAMA to do a report that says, no, please don't peer review us. Trust our science. We don't need you to double check us. We got this. What they did was a couple math equations, and they came up with 60% of people are now asymptomatic spreaders. So all the healthy people that are lifting weights and doing good and feeling the best they have in their life, they're the ones making people sick. But in China they did a test and got it published in Nature, a very, very prestigious journal. They said, yes, please review us, because we want to know if we did right, and if we did do wrong, find out where we did wrong. That's scientific method. So they enrolled 10 million participants where JAMA said, please nobody, we don't need anybody, we're going to do some calculations. So they did, Nature did a bunch of tests, and they came back with 0% transmitters. If you're sick and you're sneezing, then you have it. If you come back with a positive test, then you might not have it if you're not sick. So this asymptomatic thing is, okay. Hello, my name is Chris Butcher. I am a master.
Hey everybody, I fucked up. I'm gonna stop this broadcast. I'm trying to upload that video. I'm gonna send it to Patel Patriot. I fucked up end stream. Cool. But test. I want to test audio.